This is Dr. Sabag of the VMR Research Foundation, interpreting images that were taken with a spectral domain optical coherence tomography system that is able to render 3D imaging of the inside of the back of the eye. What you see at the bottom is a block section that was created optically of the wall of the eye. At the very bottom is the sclera, above which is the choroid. The interface between the choroid and the retina is demonstrated by bright white lines, and the uppermost layer is the retina, which lines the inside of the back of the eye and acts like a film in a camera, receiving the light that was focused by the structures in the front of the eye and transforming those photons into electrical signals that are transmitted to the brain where vision is completed. The saucer-shaped dimple in the center represents the fovea centralis, which is the center of the macula. That's just the name for the central portion of the retina. The macula is responsible for small detailed vision and straight ahead vision and is often described as the most important part of the back of the eye. In front of the macula, you can see many dark structures which represent opacities in the vitreous body. In this instance, they are organized in clumps as well as linearly, and this is most likely the result of myopia or some inflammatory condition of the eye, as well as some effects of aging, although this is not the typical appearance of an aged vitreous in an elderly individual. These structures will interfere with the passage of light to the back of the eye and create shadows that will be seen by the patient as floaters. The advantage of this particular imaging system over conventional imaging systems is that we can not only visualize the back portion of the vitreous, that area that's right in front of the macula, but also some of the central vitreous structure. The reason that's important is that conventional OCT imaging will not visualize many of the opacities inside the vitreous body that will create the sensation and visual phenomenon of floaters. Ultrasonography can image these structures and has been successfully used to evaluate patients complaining of vitreous floaters, but the resolution of sound is not as good as the resolution of light. Therefore, this imaging is superior, although the optics limit the extent of the vitreous body that can be imaged and visualized with this technology. Furthermore, this is simply a graphic illustration of the opacities, and there's no quantification of the number or size of the opacities in the central vitreous. And that would be very important for us to be able to better understand the disease process in patients who have vitreous floaters. Using light rather than sound more closely replicates the experience of patients with floaters and can image for us the structures that create the shadows that patients see as floaters. Furthermore, a need for quantification exists because in order for us to be able to gauge the severity of disease, at least on the basis of vitreous structure, it would be very useful to measure the number and size and distribution of these opacities to get a better understanding of what's going on inside the vitreous bodies of patients afflicted with vitreous floaters. When these floaters demonstrate structural abnormalities, such as the ones seen here, and are associated with visual dysfunction, in particular degradation of contrast sensitivity function, then the term to apply is vision-degrading myodysopsia. These are the types of patients who benefit from surgical intervention with limited vitrectomy, although other treatment modalities are being sought.